Welcome to How Do We Improve Communication and Collaboration in Return to Work? We're glad you're all here today. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program, through the BC government, as well as donations and memberships to WWDPI. We thank our program partners, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You will be emailed the direct links for all of these items when they're available. Our speaker today is Dr. Fergal O'Hagan. Dr. Fergal O'Hagan is currently a senior lecturer in the Department of Psychology at Trent University in Peterborough, Ontario. He completed a PhD at the University of Toronto and postdoctoral training focusing on work disability prevention. Before and during his doctoral training, Dr. O'Hagan practiced in the field of occupational rehabilitation, holding progressive positions in public and private sector organizations. He has worked with a range of clinical populations developing, managing, and evaluating occupational rehabilitation programs. His research examines individual adaptation to chronic health conditions with a specific focus on work functioning. He is a registered kinesiologist with the College of Kinesiologists of Ontario, consultant to LifeMark Health on occupational rehabilitation issues. Without further ado, I will hand it over to you, Fergal. Thank you for being here.
Okay, thanks, Yusra. So thanks a lot for signing up for the webinar today. As Yusra mentioned, my name's Fergal O'Hagan. I'm at Trent University in the Department of Psychology, and I'm happy that you could join me today for this session focused on communication and collaboration among return to work stakeholders. Before I get into things, I'm going to speak about 45 minutes or so, I would say, and I certainly welcome any questions and contact subsequent to the seminar. So, as Yusra mentioned, my background's in occupational rehab, where I developed, managed research programs for a number of decades. And I'm in the Department of Psychology. So my research focuses on factors enabling and constraining return to work, and I've done both work on individual factors such as illness perceptions, as well as more systemic factors, which I'm going to talk about today. And just on the side, I enjoy a Guinness or two and playing and watching some rugby. So I've been doing, just a bit of background in this, I've been doing research on communication in a couple of different projects over the last 10 years or so. And my interest really started with a colleague of mine who's at Morneau Chapelle now, Yvonne Steenstra. And Yvonne and I started thinking about communication and collaboration during return to work, and it sort of prompted me to take a look at some of the I guess some of the demands that are placed on participants in programs of care. So in Ontario, the WSIB has various programs of care for work injuries. And when I started looking through the documents for the programs of care, it was very interesting what they were expecting of healthcare providers in particular in the system in terms of communication with other stakeholders, including employers. And what struck me was that there was a lot of assumptions made about, for example, the amount of time that a healthcare provider might have to communicate, the resources available to them in terms of communication technologies, and as well as that, their abilities to develop and relay information about return to work. And when I'm referring to communication, I really look at it in an inclusive way, starting from the development of information that a stakeholder might have to undertake to contribute to the process. So, for example, with healthcare professionals developing restrictions for a worker to go back to work, right through making that real on a form, transmitting it to an employer, and the employers sort of taking and using that information. So I worked on a number of projects looking at these issues, and a more recent one, which my former grad student and I published a paper in the Journal of Occupational Rehab on, was related to the use of information technology in return to work. And what we looked at, we gathered stakeholder perceptions about the use of a prototype app to improve decision-making and communication during return to work. So I'm not necessarily going to share those specific findings with you, although I'm happy to answer any questions that you might have about them. But some of the research that I'm going to be talking about comes from that, comes from this work. And while I want things to be practically focused today, I'm going to be including some of my research in the talk. And as well as that, communication and collaboration during return to work is a vast topic. So we'll really just be scratching the surface today. And as I said, if you want more information, please feel free to contact me. So in terms of learning objectives, I wanted to focus on 4 primary objectives for today's session. One is in describing the communication and collaboration network involved in return to work, because I think it's important to understand how things fit together to be able to understand some of the problems that arise and perhaps some of the ways we can overcome problems in communication and collaboration. And then secondly, explain how communication and collaboration fits into the process of return to work. And what I'm going to describe here is, more or less an ideal notion of how communication might occur, in this case, between a healthcare provider and an employer to facilitate accommodation. But I also want to talk about the barriers and facilitators of communication and collaboration during return to work, and some of the problems that can arise as a consequence of those. And then lastly, I want to focus on ways and means to improve communication and collaboration during return to work. I think there are 2 main take-home messages from this session. One would be that communication and collaboration occur across a complex network of stakeholders with varying interests and agendas, situated in different systems and through a range of media. And this poses challenges for our ability to work together on these cases. And secondly, that improving communication and collaboration will require an integration of stakeholder systems through media, but also the recognition that we have a shared sort of purpose and need to undertake effort together to resolve work disability issues. That includes taking the perspectives of others involved and integrating our approaches to determine a return to work fit, including both subjective and objective information. So in terms of agenda, I'm going to start then by discussing a framework for understanding return to work communication and collaboration. And I'm going to sort of elaborate different levels which create complexity in the system and challenges for communication and collaboration. And then secondly, I'm going to talk about some of the problems with communication and collaboration that we've heard both in research done by other people as well as research done by myself and my students. I'm going to talk about sort of what we feel, or what I feel based on the research to be the major factors influencing communication and collaboration, and try to address the question of like what is good communication, and lastly then strategies to improve collaboration and communication. So as is my custom in doing these kinds of presentations, I like to start off with just a couple of cases and practical things to help ground us in talking about this. So I'm going to talk a little bit about case one, who let's call her Jane. So Jane was an accounts representative at a collection agency that handled motor vehicle loans, and she began experiencing back pain over a 6-month period. Visited a physician and was diagnosed with instability in her sacroiliac joint. She went off work and began physiotherapy treatment. She initially accessed EI benefits, and when those finished, because her disability was non-work related or determined to be non-work related, and when those finished, applied for disability benefits, and her claim was delayed for nearly a year as the insurer wasn't satisfied with the medical documentation received and refused to make any kind of contact with her healthcare providers directly to request clarification. And Jane's case will come up again as we move through the talk. And ultimately, her physiotherapist had to write a very detailed letter explaining the diagnosis and providing information connecting the diagnosis to her functional impairment. Eventually, her claim was accepted, and in her case, thankfully, her employer was very supportive in accommodating a graduated return to work plan. And case two, so case two we'll call Judy, and she's a nurse at a hospital. She experienced work disability as a result of a cancer diagnosis, and then subsequently suffered injuries in a car accident when she hit a moose, and was left with significant soft tissue injuries. So what this wound up creating was a situation where she had these sort of two return to work issues that came up along different timelines. And in her case, again, the insurer balked at her benefit claim despite healthcare provider information being provided. She initially made her HR and occupational health and safety departments aware of her intentions to return to work and her situation following the motor vehicle accident, but then didn't contact the employer any further, and her employer didn't contact her. And owing to a lack of communication between the parties, her supervisor posted her job, and it was taken by a coworker without her knowing. Her union wasn't made aware of the situation either. But once made aware, the union intervened, and she made a successful graduated return to work, recovering from the motor vehicle accident injuries. But following this, her cancer condition worsened, and she had to go again to go off on sickness absence benefits. And this time, having learned from the mistakes of her first episode, she remained in close contact with her union, HR, occupational health and safety, and supervisor, and along with her healthcare providers, a successful graduated return to work was planned and executed. And then case 3, so let's call this one John. John hurt his shoulder when he fell off a ladder at work. Trying to tough it out, he continued to work for the next 2 shifts, but on the third, he could barely move his shoulder. He reported the injury. The employer didn't submit a Form 7 disputing the claim of work-relatedness, basically questioning John, why did you continue to stay at work if you were that hurt? He was diagnosed, went to the ER, was diagnosed with a shoulder sprain, referred to a physiotherapist, but didn't recover as expected. He was referred to the compensation assessment. At that point, the specialist confirmed a shoulder sprain. Physiotherapy continued. His condition worsened. He was referred by his doctor for a second opinion. The physio felt that he might have a labral tear in his glenohumeral joint. Labrum's a little lip around the very small socket in the shoulder, and it can get torn. So this was confirmed at the next specialist consult with an MRI. And John was booked for surgery and continued physio. In the meantime, the employer continued to reluctantly support accommodation. They involved 3 different return to work specialists, and John indicated that there was confusion and differing opinions on the type of accommodations he was to receive. Functional abilities forms were submitted, but restrictions such as no ladder climbing were disregarded by his employer and the return to work specialists. And he was eventually terminated by the employer and continued into in a WSIB vocational rehab program. So I guess when I think about cases like this, I think about so what are some of the common threads here as they might relate to communication and collaboration among providers in this situation? Well, I mean, obviously all involve disabling health conditions. All of them involve some degree of complexity. They're not your typical, let's say sort of ankle sprain, rest, ice compression, elevation, stay off it completely for a couple of days, gradually reweight it, and you're off to the races. So they're disabling health conditions involving some degree of complexity. I guess what when you look at cases such as these, it's really incredible how many people wind up being involved in this. So we have across the cases and in varying degrees, we have HR people, we have occupational health and safety people. Inside the workplace, we have supervisors involved in work reintegration. In the healthcare system, we have primary care physician, physiotherapists, specialist involvement, both through the workers' compensation system and outside of the workers' compensation or disability insurance system. In those systems, we have claims adjudicators, individuals responsible for managing return to work specialists. So there's huge complexity in terms of the social involvements in this process, and it really highlights the very social nature of return to work. And I think, and you know, as I'll talk through, we've got people coming in from these varying systems in which, you know, there are very different cultures of communication and information flow. So sort of setting up, I think these cases sort of set up our situation in terms of return to work communication. So why focus on communication and collaboration at all during return to work? Well, I think the cases I just talked through a little bit give you some idea about it. But in research, there's pretty strong evidence for workplace and healthcare provider contact reducing disability duration. So not so much improving health-related quality of life for workers, but certainly getting them back to work more quickly. And some researchers have gone so far as to say that good communication and cooperation between stakeholders results in a harmonization of perceptions and people working together, sort of a concerted effort towards resolving the work disability issue. Well, I think this might be a little bit idealistic. This sort of evidence and thinking has led people to include communication as one of the 7 pillars of successful return to work, and the Institute for Work and Health includes stakeholder communication among their 7 pillars of successful return to work. And this has led to programs of care, for example, a workers' compensation board in Ontario, including including demands on care providers to include communication in their care plan, basically. So the WSIB program of care for acute low back injuries insists that the healthcare provider, usually the physio or chiropractor, contact the employer by phone or letter, inquire about the demands of the worker's job, and contact the employer about return to work. And all, you know, under the presumption that the provider is ready, willing, and able to undertake this. Yet, communication, it remains a difficult thing. So program evaluation and research suggests that let's say a good number, but certainly not all chiropractors and physiotherapists regularly communicate with employers. And a colleague of mine, Glenn Pransky, did a survey of Massachusetts physicians and found only 12% of those responding physicians regularly communicated with employers. And while these data might seem a little bit old, actually there's been very little change in the situation. The other thing with the research base and assumptions is that the evidence for communication primarily relates to studies where specialized teams have gone to workplaces who were ready, willing, and able to collaborate with healthcare providers to resolve work disability issues. And the interventions, you know, involved a lot of communication back and forth between workplaces and healthcare providers. And this isn't necessarily the case in day-to-day practice. And that's actually where I've been focusing most of my research, because, for physicians working in the community, or physiotherapists working in the community, or mental health practitioners working in the community, the situation can be very different. And as well as that, not all workplaces are willing to step up to do the kinds of things that are necessary to work with other stakeholders in the system. So while communication is, it's undoubtedly likely a good thing, there are still a lot of questions as to how it can most effectively operate, and particularly at the level of the community. So models have been built to try and understand communication processes between people. And one of the earlier ones built decades ago was a Shannon-Weaver model of communication. And most models still, take a fairly simplistic approach to how information gets back and forth and it is used. And so, for example, the Shannon-Weaver model conceives the communication processes involving a reciprocal sender-receiver loop where the sender encodes information that's transmitted one way or another to a receiver who decodes the information, makes sense of it, and then responds in kind. So in the return to work situation, you might imagine a physician completing a functional abilities form for an employer. So the physician needs to infer information, mainly from patient report, to code that information onto a functional abilities form. So, lifting up to 10 kilograms, no limited sitting, no forward bending, et cetera, and then forward to an employer who needs to decode it and apply it to work accommodation situation. In between, there's the signal being sent and received, or noise can be introduced, either through interference or through the nature of the communication channel. And the receiver, having received the information, then can respond in kind, and things can go back and forth. So while this kind of a model gets at some of the aspects of the basic processes, there's a number of reasons why these kinds of simple models don't stand up in terms of in a return to work situation. Now, for those of you who have seen me present before, you've probably seen this slide, which describes the arena of work disability. And I think it's important to go back to it here in the context of communication, because it really helps us understand sort of the lay of the land in terms of who's involved and what's at interest here. So colleagues of mine developed this model a number of years ago that describes the systems involved and in the return to work situation, and their interactions. And they likened it to an arena because of the sometimes contentious nature of work disability. So in the arena, you have the worker with a work disability in the center, and surrounding the worker, you have a personal system, a workplace system, a healthcare system, and an insurance system. And each of the systems plays a role in either maintaining or reducing work disability. So the personal system is the system of the worker, and that includes the worker's physical status, their thought and emotional response to illness, and immediate social relations with families and friends. The workplace system includes the worker's job position and its various qualities, such as physical demands, the immediate relationships the worker has with coworkers and supervisors, qualities of the organization responding to work disability, and aspects of the external environment, such as economic conditions that might affect the labor market and prospects of the organization. The healthcare system, so this is involved in providing medical and rehabilitation support to the disabled worker, and includes the worker's attending physician and allied health providers involved in the worker's immediate treatment and potentially multidisciplinary and interdisciplinary teams involved in care. And then lastly, the legislative and insurance system. So this includes the immediate claims adjudicator and manager and other insurance personnel such as caseworkers and the legal framework that bounds the system. So just talking through the various systems and stakeholders involved, you can get an idea of how much how many people are involved and sort of the complexity of things, but really that, you know, each of these sort of systems or stakeholders has their own individual interests in mind when approaching a return to work situation. So the worker with a work disability wants to sort of balance the demands between their health, which has failed in some way, and the productivity demands of the workplace. You know, in the workplace system, there's a production imperative there. They need to get work done, they need to get output, they need to ensure the economic success of the organization. Within the healthcare system, the treating physicians have an obligation to the well-being of the patient. But you know, physicians and other healthcare providers also have more selfish interests in that, you know, if you go into any GP or family physician in Peterborough here, let's say, they're operating a small business and they need to operate things in an efficient and effective way. And they need to ensure that they're meeting regulatory compliance with their college and safeguarding patient information, for example, because there can be significant consequences to that. In the insurance system, the bottom line again is very important there. Representatives within that system are concerned about the amount of money that's going out the door for wage replacement benefits or healthcare expenditures and that kind of thing. So each sort of system comes with its respective interests. And then when we look at the communication network that surrounds the worker, it's complex as well. So within the multiple stakeholders we have in the system, we also have multiple channels of communication. So at the level of the worker, you have interactions between him or her, a healthcare provider or two, let's say general practitioner, family physician, and a physiotherapist or a chiropractor or a psychologist or social worker, depending upon the work disability situation. Worker interacting with a workplace representative or more. In large workplaces, you could have human resources, occupational health and safety involved. In a small workplace, it might just be the supervisor or owner. And sometimes you have a return to work coordinator or union person thrown in for good measure. And of course, then you have the insurer or workers' compensation representative interacting with the worker, potentially interacting with the workplace and the healthcare provider. And the dotted line between healthcare provider and workplace suggests that information exchange and communication can be direct, as it would be between the worker and these people, but oftentimes is indirect, taking place through primarily paper-based media. For example, functional abilities forms are typically used to transfer information from healthcare providers to workplaces. And at the center, the worker often becomes the carrier of information between healthcare providers and workplaces. And I guess the model also points to the information-rich and dependent nature of the return to work process. So each of the people involved produce different forms of information necessary for return to work, and each of the others is dependent upon that information to properly fulfill their role. The worker has information about his or her experience with injury or illness, with its associated symptoms and perceived functional limitations. The employer has information about work and the policies and practices relating to disability management. Healthcare providers develop and provide information about the health condition and functional capacity, and the insurer has information about benefit entitlement and support. So this kind of web of communication is inherently vulnerable to miscommunication and misinformation. Apart from the multiple players, knowledge-based bases and interest, stakeholder communication occurs across separate but interfacing systems with communication channels operating back and forth. So these systems can have particular communication practices and use different media. For example, still a high proportion, 60% in 2010, of communication in physicians' offices still takes place through fax, believe it or not. Communication practices are regulated within a social and legal context. I'll pop that up there, putting restraints on certain modes of communication. For example, the exchange of health information by healthcare professionals has significant constraints placed on it. Also, healthcare providers answer to regulatory colleges whose primary interest is to protect the workers as patients. College complaints are a major source of stress for healthcare providers. So communication and collaboration are dependent upon the smooth flow of information across these systems, which we know is not always the case. So right off, we have a complex situation for communication and information exchange. And then when we look at the process of communication, while seemingly straightforward, there's also multiple places where problems can arise. So if we look from the bottom left proceeding through the diagram, in the workplace system, when a work disability issue arises, an employer will activate and make a request for information from a healthcare provider who will receive the request, activate and determine a response. It may be completion of a form, let's say a functional abilities form, reify that information on the form, getting the information down, and then transmitting the information to the employer who receives it, assesses the quality of it. If judged to be adequate, then is able to use that information and observe the resolution of the work disability situation. If deemed inadequate, the employer has to go through the cycle again and obtain information. So lots of different points at which information development and exchange can break down here. So problems with, not surprisingly, problems with communication and collaboration have been identified by all stakeholders, so workers, employers, and healthcare providers. And on the part of workers, what we hear is physicians not spending adequate time and understanding their work situation, employers not respecting limitations that are put forward in functional abilities forms, and workers also talk about the onus placed on them to act as a go-between on top of the health issues and financial stress that they're experiencing. In some of our research, we've heard from workers such as this one. So my employer knew that I was off and why, but really unless I initiated communication, there wasn't any. I guess they don't want to harass you when you're off, but it would be nice to have a call to say, how are you doing? Are you thinking about coming back? With respect to the case that I talked about at the start of the talk, what became evident was the insurer basically told the worker that they weren't accepting their medical information because they felt that the doctors are lying. And so this individual went without benefits for over a year's time, which can throw all kinds of problems into the return to work situation. But went without benefits for that amount of time because of the subjective judgment of an adjudicator. Employers talk about issues with communication and collaboration. So, employers will often refer to healthcare provider information as tardy, lacking quality, and being inadequate for the purposes of accommodation. They talk about bias in healthcare provider information and taking dictation from workers because of advocacy concerns. But interestingly, I mean, this isn't, employers don't paint all healthcare providers with the same brush. The employers that I've talked to in my research tend to view physiotherapists, for example, as providing more objective functional information for return to work. And as you can see here, as expressed by this employer, most physicians take dictation. Sometimes healthcare providers will overstep their bounds and identify accommodation that the employer should pursue, which is really not their role to do. And on their part, sometimes that's just misunderstanding as to what they should be doing with the return to work situation. And as I suggested here, the employers that I've talked to tend to favor, at least in musculoskeletal disability, information from physiotherapists that they feel is providing much better detail and enabling accommodation. There's problems, employers talk about problems with forms a lot. Here's an example of a functional abilities form where the physician is simply indicated currently unable to work in any capacity for reassessment in 1 week, and left all of the abilities and restrictions blank. Contrast this information received from a physiotherapist where very detailed information is given about restrictions around repetitive activities, the amount of time that should be spent with that, and emphasizing no repetitive activities to take place. And functional abilities form here has been provided to the worker and the employer. And likewise with this form, further detail provided to enable accommodation. So lots of variability in terms of the information provided by healthcare providers, and it's not just employers whining about it. Healthcare providers also say there's issues. They complain of inadequate training and expertise, particularly in psychosocial issues. They find form completion frustrating. There's a lack of perceived relevance to practice. If you talk to physicians, and I have in the context of research, they really don't see how 6 years of medical training has any relevance to them filling out a functional abilities form. They perceive at times a lack of employer support for accommodation, and a lack of time within their practice and reimbursement for their time. Some of the things that we hear, so while employers sort of characterize physicians as taking dictation and being biased, when you talk to physicians about it, you hear a somewhat different story. So in this case, this physician indicates, my personal bias is that the sooner you can return to work is better, and so you probably tend to lean on the side of more frequent assessments so you can get someone back to work faster. Although physicians do acknowledge that a lot of the information that they provide for return to work is based on the subjective report of the patient. But when you think about a physician practice, and the amount of time that they have, the lack of equipment and resources they have, even if they were to, be inclined towards testing patient function, they don't have any equipment to do that. So they, as they indicate, so it's not very objective. It's mostly based on patient self-report, and it really, it can't be otherwise. And here's a physician who's telling us a little bit more in terms of what is considered in making return to work determination. So I take the information that physiotherapy gives me, take the information that I get from diagnostic imaging, from other specialists, and I put it together and give the best opinion I can. And when you talk to physios, they'll elaborate that further. And basically, it's a triangulation process of putting information together to make the determination. So because we haven't gotten to the point now where, if you remember on Star Trek, where Scotty had that little scanner that he could just wave over people, we haven't gotten those yet that determines whether or not an individual is capable of heavy work demands, of light work demands, or so on and so forth. So kind of pulling this together, what are some of the factors influencing communication and collaboration? Well, I think we see complexity of workers' health condition being a significant one, particularly where you have psychological and pain conditions that are not necessarily objectively measurable. They create, a lot of questioning and a certain amount of distrust within people involved in the system. Or a worker with multiple needs, such as the individual who got into the car accident and also had a cancer diagnosis to deal with. Knowledge of and attitude towards disability management. So this is both on the part of physicians and employers. So physicians, for example, there are still physicians that really, question the value of early, safe return to work. There are employers who question the value of and requirement for accommodation. The nature and location of return to work assessment. So, by its nature, doing a return to work assessment in a physician's office cannot but be based on subjective report. If you go to a physio clinic with a gym, there's a lot more opportunity to observe the motor functions of the patient and make a determination on, and spend more concentrated time with them, and come to a more, let's say, objective determination. Healthcare provider knowledge of work and workplace policies and practices. Like physicians, and they'll tell you this, they're not they're experts in diagnosis, prognosis, and treatment. They're not experts on work and workplace policies and practices. And some of the physicians that we've talked to would prefer that judgments around functional ability determinations be offloaded to OTs, PTs, or kinesiologists who have greater expertise in the areas. Healthcare practitioner practice economics. So here, the healthcare practice efficiency is a primary concern in the healthcare practice, and remuneration is an issue for all the healthcare practitioners that I've spoken to, and making return to work recommendations. And then varying expectations regarding return to work timing among workers, employers, and healthcare providers. Workers, they still tend to view return to work, for some of them shouldn't happen until they're fully recovered. Employers feel that as soon as an individual is able to undertake anything that could be accommodated, they should be back in the workplace. And healthcare practitioners varying in terms of what they might expect, although I'd say that there is an interest in getting workers back into the workplace in as expeditious a manner as possible. So what makes for good communication? Well, we think that really there are two things. One is the utility or usability or the what of the information that is provided. And the information provided should be able to inform accommodation, adjudication decisions. It should enable other stakeholders to do their job. So information provided by healthcare providers should be adequate to enable employers, provided that they're equipped to do so, to identify ways and means that they can accommodate the worker in the workplace. And communication should also promote and maintain positive relationships among stakeholders during the return to work process. And then secondly, there's sort of a how around accommodation, around information. So stakeholders involved, it needs to be effective in that the stakeholders involved need to view information, the information that's been developed and provided, as credible because of a proper procedure. And that gets at, issues around dictation and the subjective nature of information development that takes place in physician offices, for example. Information should be provided in an efficient way. So it should be competent, well organized, and economical. Information should be provided with consistency according to procedural and legal requirements. So, for example, requirements laid out in legislation like PHIPAA or that kind of thing around sharing health information. Communication should take place in a way that helps people to work together. So an example that I am experienced with in a clinical setting is when injured workers sort of operating in their interest might help or might attempt to split a treatment team by sort of setting them off against each other, causing them to question each other in terms of their handling of the patient. And then personal congruence. So communication should be, in some way promoting the interests of the stakeholder themselves. So some of the root causes of communication and collaboration problems. Here, I think one thing is where, who, and how return to work decisions are made, and the situated nature of reasoning. So as I've alluded to, even if a physician were expert in determining functional abilities, coming into an exam room, having a patient sitting in front of them, asking them questions, maybe getting them up, maybe having them get up to touch their toes, do a squat or something like that, doesn't provide the kind of information that's needed in order to process and make good determinations around functional abilities. So that's one of the issues that I think is important. The media used to communicate return to work information. So forms and guidelines here, and this gets at the old idea, the medium being the message. So if you look at a return to work form, it's got tick boxes for lifting this and sitting and standing, but we know that with problematic return to work cases, the issues relate to psychosocial barriers and impediments. And it's rare that I see those kinds of things addressed in the communication media that we use, and I think that that's a problem. Knowledge and ideas around how return to work decisions are and should be made. So employers, in the research that I've done, talk incessantly about the need for objective information. And I agree that the closer we can get to something that really identifies the underlying capacities of the individual, the better. But I think it's unrealistic to have that perspective in the day-to-day practice that occurs in physicians' offices. And I think that we need to come to some, we need to be sort of settled in our ideas around this and realize the constraints that exist that do not permit objective information to be obtained at every step of the way. The common good versus individual interest. So as I mentioned at the outset, individuals, everybody is coming into the situation with a selfish interest, a portion of selfish interest, a portion of altruistic interest, and a portion of collectivist interests. And the more we can sort of enable the altruist and collectivist interests to emerge in the situation, the better. And lastly, sort of relating to perspective taking, assuming the motivations and actions of others are negatively motivated. It's not, when a physician is sitting down with a patient, it's not in the back of their mind, I don't think, that they want to, make things hard for an employer here. But they're sitting in front of an individual who's, crying or pouring out their life story to them, and all the difficulties and all of the badness of their work. And they have to make a decision in that interest that's going to be in part a very rational decision and going to be part emotionally driven. It's not that they're sort of have ulterior motives. So how do we improve communication and collaboration? Well, I think that we need to have communication tools that integrate the needs of various stakeholders. So for example, in using, let's say, an electronic media tool, providing voice for the worker, having guidelines for employers and insurers, and help, well, voice for workers, guidelines for employers, insurers that healthcare providers can use, and enabling features that allow people to identify psychosocial barriers that are going to be going to get in the way of return to work. Secondly, enabling perspective taking on the part of stakeholders through embedded information, education, and direct communication where possible. So where we can share information about the varying perspectives that people have, either sort of implicitly in a form or more explicitly through educating them and enabling some direct communication. Number three, be practical in acknowledging the limitations in assessment and determination of return to work function. And here, my grandmother used to say, you can't make a silk purse out of a sow's ear. You cannot, with present technology, you cannot make a physician's office a place where you're going to get really reliable, objectively determined information about physical function. And some conditions, such as mental health conditions, just you can't enable that full stop. Acknowledging the social dilemmas and interests on the part of different stakeholders in the return to work process. So as is possible, identify shared interests and avoid position taking when negotiating a return to work. And I think in terms of assessments, using the right person at the right place at the right time to make return to work assessments when they're needed. And here I would suggest that, if a physical medicine practice, for example, is a more ideal place to make return to work assessment determinations than, a 12 by 12 physician's office, or at least giving information that will contribute to determination of return to work. So I'm going to wrap it up there. I've run right to the end, but I am happy to take any comments or questions.
Thank you so much, Fergal, for this compelling presentation, and thank you for incorporating a real-life case examples, and actual quotes from employees, employers, and healthcare providers to give them their own voices. So immediately we'll start our Q&A session. I'll let the audience insert their questions in the question box, and I'll start off with the first one. So in the case of Judy, you said that the employee didn't get in touch with her employer, and the employer didn't contact the employee. So in this situation, who is required to reach out, or what should be done in this situation?
Well, with so Judy's situation was she was covered by long-term disability insurance. So with a private contract of that nature requires it can require the individual to mitigate the disability situation. In which case, Judy has an obligation to, like, part of mitigation is getting in touch with employers, and that's laid out specifically in workers' compensation legislation, for example. Both the employer and the worker have obligations to mitigate the disability. So she would have an obligation to be in touch with her employer, and were it a WSIB case, it would be explicit that the employer has an obligation to reach out with her or to her.
Thank you, Fergal, for the explanation. And so identifying some of the barriers is definitely a pillar to improve and return to work. So I believe you answered that in the last part, but if you can do just some kind of summary, but how can we eliminate some of those barriers?
So I think there is, as I suggested in number one, I think there's a place for technology here. I think that we can move towards developing technology that will work across systems, because one of the problems that you have in this area is not everybody, but you can have very different communication cultures, and including media within the different systems. So it's hard to talk across systems. But I think that there's opportunity here to develop communication technologies that will enable that. The app that we studied had some nice features. The users, they found the usability to be good. They believed that it was feasible for practice. But one of the major barriers, when we talk to healthcare providers and employers, it was like no one wanted to kind of get on board with something like that unless it was going to be system-wide. So developing technology, I think, needs to be done initially, testing it out to see how it works in a small way. But when it's deployed, it has to be, sort of deployed out into systems. So communication and information, or communication technology, I think, will play a role. Enabling perspective taking on the part of stakeholders. So I think part of the issue, at least, when I hear from from both employers and healthcare providers, is that they really don't understand what the challenges the other person faces in the system, and what challenges employers might face with in accommodating and still getting the work done, right? Because that has to happen in workplaces. And I think taking measures to enable perspective taking is really important. I think this notion about objective and subjective information, it really plays, and it relates to perspective taking, but it really plays an important role in things like, employers need to realize that you're not, you can't get objective information out of a physician office with the technology and their focus. Like, physicians are not oriented towards that. They want to make diagnostic determinations and treat patients. They don't want to be testing their function, and so it kind of relates to the last point. Systems should be moving towards a situation where you have people who are properly equipped to make these determinations doing them. And then also when, you know, the fourth point there, acknowledging the social dilemmas and interests on the part of different stakeholders. So here it's about, like, look, everybody here has a selfish interest, and let's get that out there right away, right? But to the extent we can, let's identify, you know, what are the shared interests here. Like, certainly there's an interest. A worker, I believe, a worker is more empowered, is more of an agent, can take care of themselves better when they're back to work. And so I think, you know, common interest revolves around getting people back into the workplace. And so working from there as a shared interest, and avoiding taking positions, which really, when positions are taken, that really limits the our ability to think of creative solutions for return to work. So, I mean, I think these are things that I would encourage in the system. Yeah.
Thank you, Fergal. Those are excellent points, and I believe your presentation was very comprehensive because we don't have any further questions from our audience. So,
Okay.
Fergal, thank you so much for making the time to be with us today and for sharing your valuable expertise. And we also thank our audience for their interest and participation.